I'm going to introduce Dr. Sharifi to speak. The first talk he's going to give. There are a lot of new thrombectomy devices, and I'm interested in hearing what you have to say. Welcome.
Good afternoon, everybody. My name is Mohsen Sharifi. It's a pleasure to be here, and I'd like to thank Patty for the kind invitation. We will start with, first of all, I don't have any disclosures. Now, if you see somebody presenting with this leg, this is not just a regular DVT. It's not a popliteal DVT alone. It's not a femoral DVT alone. And there is always some cephalad involvement, and not in vacuum. There's probably an obstruction in the iliac venous system as well. And trying to give the same recommendation for a popliteal vein DVT to this kind of presentation, I think, is a disservice to the patient. These patients have 15% chance of venous ulceration with just conventional management. Venous claudication occurs in at least 20% of these people, and reflux or insufficiency in about 90%, and PTS can happen in at least 50% of these people. Now, dating back to 1.5 decades, the major societies have identified this problem. Starting with the Society for Vascular Surgery, they made a 2C recommendation for percutaneous endovenous intervention. Society for Interventional Radiology as well. American College of Chest Physicians in 2008 made a 2B recommendation for select patients. However, I think due to some misunderstandings of the data in their subsequent iterations in 2012 and 2016, they retracted that, however, made a neutral comment that in patients who do not want to get PTS, they may choose endovenous intervention rather than conventional treatment. As far as devices, which is the major topic of this discussion, there are numerous ones, and I cannot possibly go through each and every one of them. I will tell you what they claim and then my own interpretation at the end. The most recent ones are in the bottom left, but they are numerous. In general, we can subdivide, we can classify the mechanism of these devices into 4 broad categories. Those which purely rely on a catheter for delivery of thrombolytic agents. They can be passive, such as the Craig-McNamara Unifuse or the fountain catheter, or active when you have the infusion plus ultrasound. Then there is the class of aspiration only, and there are a number of those. Jedi, 8 French, Indigo, we'll see the lightning category, and angiovac. Then there is a type which has oscillation or maceration with or without thrombolytic therapy. 2 of these were retracted, Tretola and Trellis in the past. Then we have aspiration and mechanical. Now, this is from one of the companies, Inari, and you can see it has given green check marks for itself, and the competitor has all red marks. But there is some truth to some of those claims. Now, bear in mind that DVT does not happen in vacuum. This is, for example, why you have more DVT in orthopedic surgeons, and they recommend prophylaxis. The iliac vein has been damaged. And again, in patients who has had plating, you can, if this was an angiogram from the arterial perspective, you would say there's probably nothing there, but looking with intravascular ultrasound, you can see significant stenosis. This is one of our patients who had radiation, young person with severe iliac vein stenosis before and after stenting. So starting with the Inari, this has been in use for several years now. There's the ClotTriever. There's for DVT, FlowTriever is for PE. ProTrieve is a form of a removable filter. The InThrill is another one of their toolboxes, which is for smaller veins. RevCore is for in-stent restenosis within the venous stent. FlowStasis is a closure device. I don't think that's really indicated in the venous circulation, but there it is at an expensive cost. And there's a FlowSaver, which is not a bad idea, and that re-injects the blood into the patient's circulation after filtering it. And this is the mechanism. A basket advances more cephalad to the thrombus and then retracts it. And you will always be seeing all these phenomenon pictures of extensive thrombus before and after. Angiovac has been in use also for a number of years. Initially, it came with 22 French and 26 French. Now it's down to 18 French. It needs a venous-to-venous cannulation. There is filtration and return of the removed blood into the circulation. Trellis was used way back. It was retracted from the market, from the US market. It's an oscillation and TPA device. This is when I was first using it. There's really no magic to it, but it's a reasonable oscillator. This is a newer aspiration device, Quick Clear from Philips. These are expensive catheters, by the way, and anywhere from $5,000 to $7,000 is sold to the hospital. Cleaner is from Argon. It's a rotational atherectomy. This is when I was using it in a filter obstruction. It does provide some help. Now, Merit has a fountain system which claims that with more pressure it can get a better output than regular infusion catheters. Prodigy is the newer version, I think was approved a year ago from Imperative Care. Again, another oscillation and aspiration. Jedi has been in use for a number of years. It uses a hydrodynamic thrombectomy system, generates a Venturi negative pressure effect, and sucks out the clot. Arrow was retracted. It's a basket with infusion of TPA. The basket became broken. Penumbra or Indigo has the CAT system, and that's their claim of fame. It's computed-aided thrombectomy. On the right, you see the arterial version. On the left, the venous. The lightning is what's used for the venous system. Angiojet has been in use for over a decade. Power pulse can be delivered with TPA, and then the aspirated thrombus can be done with the same catheter. Again, it has the arterial and venous system. The Zelante has been used for the venous portion. And they claim the Zelante is far more powerful than the Solent system. ECOS is the Boston Scientific. It delivers the TPA, and they claim that with ultrasound, it can macerate the fibrins and make it easier to dissolve. In my view, I don't think it's the ultrasound. I think it's the TPA which is doing the job. So we have nearly 30 more devices seeking IDE 510K clearance in the pipeline. My personal perspective, I don't think there is a miracle catheter, and I think only a minority require expensive devices. We have to use our common sense and logic. The key question is, can the patient tolerate low-dose thrombolysis? This is a patient which came in and obviously had extensive DVT. Now, I call these a venous segment, femoral popliteal and the iliac. If you have something like this, no matter how much device you use, ultimately they use the device and they say, well, we still need overnight TPA. So this is my version of it. You put an infusion catheter, deliver low-dose TPA, look at the patient next day, probably they need stenting, and they get, within 24 hours they can go home. This is me. I use my own ultrasound micropuncture needle, access through the right popliteal venous system. You look at it through the ultrasound, and this is the subsequent result in somebody with that presentation. The key question is whether thrombolysis can be used or not. If not, then you have to familiarize yourself with one or two catheters depending on hospital policies, cost, ease of use, availability, support, etc. I use the popliteal access. You can use the femoral. Irrespective of anticoagulation status, you can do the procedure. Low-dose heparin, remove the sheaths within 24 hours. At the maintenance dose of anticoagulation regimen, low-dose aspirin and home the following day. And in summary, let's keep it simple, and simplicity is the glory of expression. Thank you.
Dr. Sharifi, thank you for that talk. And it's a lot to give in a few minutes, but are you using this as an outpatient, and is the cost of these devices a factor?
I do not, in the OBL, for patients who have extensive DVT, I do not use them because, for the simple reason that they have to get thrombolytic therapy. I prefer to do them in the hospital. I know there are some others who use the devices within that center and then send the patients home. I haven't do it for safety precautions, but I do the ones which have, iliac vein stenosis. They don't have a component of DVT and do not need thrombolytic therapy.
Okay, thank you.
Yeah, thank you.
Any other questions?
I have a question for Dr. Sharifi. We discussed the 2-week window to treat acute DVT. However, often we see organized thrombus, even fibrotic tissue. And can you give a comment on what devices work on even months later and why they work?
If I understand correctly, you're asking what catheters work for the chronic type of DVT. Is that it?
Yes.
Yeah. There is, you see, dividing it to acute and chronic is a very simplistic method of thinking. They use it, I use it sometimes too, but in reality, patient to patient is different. There's always, even in the acute version, there is a component of chronicity. We see about 50% of the time they have had evidence of previous venous insults. But to answer your questions, the ones which can scrape out something are probably preferable. Some form of a basket like the Inari has. Now, I don't have any affiliation with them, but once you go and open a basket, there is some mechanical force, and you're retracting that. It brings out not only the acute, but also the component of chronicity and fibrosis which is attached to it.